Patients with diffuse large B-cell lymphoma that fail to achieve a complete response or relapse early after standard frontline immune chemotherapy have a poor prognosis and are commonly considered to have primary refractory disease. However, many different definitions have been used in clinical studies and in clinical practice to define primary refractory disease. Some only include patients who have failed to achieve a complete response by the end of frontline treatment, whereas others include patients who achieve a complete response but relapse early, most often within 3 or 6 months. In this study, we examined variation in the time to relapse used to define primary refractory status and the association with response rates to second-line therapy and survival outcomes in patients with large B-cell lymphomas in a single-center prospective cohort, the MERT cohort, with validation in an independent multi-center cohort, the LEO cohort. The MERT cohort included 949 patients with large B-cell lymphomas, and the LEO cohort included 2,755 patients across 8 centers, with all patients treated between September of 2002 and May of 2021. Predefined subgroups of primary refractory large B-cell lymphoma included stable disease or progressive disease during or by the end of frontline immunochemotherapy, or primary progressive disease or PPD subgroup, patients with a partial response at the end of treatment PR subgroup, or those with a relapse within 3 to 12 months after achieving an initial complete response at the end of treatment, or early relapse subgroup. Patients included were treated with curative intent chemotherapy. Patients with significant dose reductions or therapy delays were excluded. We found significantly inferior response rates to second-line therapies and overall survival for patients in the PPD group compared to other subgroups of primary refractory disease. Patients with PPD had lower overall and complete response rates in both the MER and LEO cohorts. In the MER cohort, PPD patients had a 40% overall response rate and an 8% complete response rate, compared to 60 to 70% overall response rate and 10 to 36% CR rate for patients with end-of-treatment PR or early relapse. The LEO cohort had improved response rates across subgroups, but the trend was similar to the MER cohort. Patients with early relapse had a 66% complete response rate compared to 39% for patients with end-of-treatment PR and 24% for patients with PPD. Patients in the PPD group proceeded to autologous stem cell transplant and CAR-T less, despite comparable rates of patients receiving second-line chemotherapy regimens with intent to proceed to either auto-transplant or CAR-T. The 2-year overall survival for patients with PPD was 15% in the MER cohort and 31% in the LEO cohort, compared to a 2-year OS rate of 38% in MER and 50% in LEO for patients in the end-of-treatment PR subgroup, and a 2-year OS rate of 44% in MER and 58% in LEO for patients with early relapse. The 2-year OS was not significantly different among subgroups of patients in either the MER or the LEO cohorts with early relapse disease when subdividing by those who relapsed within 3 months of end of treatment, between 3 to 6 months, or between 6 to 12 months. The lack of a consensus definition of primary refractory disease has limited dedicated clinical trials for this important subgroup of patients and has had a major impact on the interpretation of historical studies in relapsed and refractory large B-cell lymphomas. Based on the results, we advocate for the following definition of primary refractory large B-cell lymphoma as stable disease or progressive disease during or by the end of frontline treatment. This is the group of patients with clear chemo resistance and most in need of better treatment options. This definition can be used to inform clinical practice, future clinical trial design, and aid interpretation of clinical research and trial results. However, better understanding of disease biology is still needed to help identify patients at high risk for primary refractory disease at the time of diagnosis and facilitate the investigation of novel frontline and salvage therapies.